Association. We're here in opposition to AB 2497 by Assemblymember Johnson. We want to thank the committee and the chair for the recent amendments relating to prescribing and image ordering authority. However, we still have significant concerns with this bill's provisions relating to direct access to physical therapists and physical therapists performing dry needling services. Physical therapists are valuable members of the care team, but eliminating or limiting physician involvement at the front end of care will create risks for patients. Our concern is not with physical therapist care itself, but with using physical therapists as the first and sole point contact for undiagnosed conditions. Physical therapists are trained in rehabilitation, movement, recovery, and functional improvement. Physicians are trained to evaluate the full range of systemic diseases, order diagnostic workups, and manage complications across organ systems. Direct access will bypass that level of medical evaluation some patients need before treatment begins or for it to continue. A patient's symptoms can represent more than a musculoskeletal problem. They may have underlying vascular and neurological conditions that could present like a musculoskeletal issue, but ultimately cannot be resolved through physical therapy alone. Physicians' involvement is essential in protecting patients through diagnosis, coordination, and escalation to emergency specialty care as needed. This bill does not account for that. Regarding our second concern, dry needling requires inserting needles through the skin into the muscle and soft tissue. This is an invasive treatment that creates risk for infection, bleeding, nerve injury, and while it can be rare, can lead to a collapsed lung. Physical therapist training appears to be minimal in this space, and a short postgraduate certification course is not equivalent to the broader medical education acupuncture training required by professions historically authorized to use needles. Just because some states have done this does not mean that California should. For example, would we ever take the lead from some of these states on reproductive health care? No, and nor should we. Every state sets its own healthcare laws based on workforce needs, regulatory structure, payer systems, and patient population. Our state has a large and diverse population. Even low-frequency adverse events, inconsistent training, or care fragmentation can affect many more patients when scaled statewide. There are better solutions than presented in this bill. For these reasons, we ask that you vote no on this bill today. Thank you, and I'm happy to answer questions.
Thank you.